What are the geriatric syndromes? We have a Benjamin West painting here of Adam and Eve. Eve may have taken a trip or slip. CMS expects that providers will ask annually whether the older adult has fallen in the past 6 months. We like to find out if they've fallen within the past year, particularly if they've had 2 or more falls. Also, what counts as fear of falling? If somebody is fearful of falling, they have a very high risk for falling in the future. You want to ask if they have any concerns about gait or balance. This Medicare Merit Incentive Payment System, or MIPS, has different metrics for quality outcomes in older adults. One of those is to ask if somebody was screened or said that they fell in their clinical exam, then proceed to a multifactorial risk assessment for that positive fall history. It's important to not only look at the intrinsic elements of falls, such as the wobbliness or gait imbalance, but also ask them about extrinsic factors, such as things at home that might cause falls, like a lack of slip or anti-slip guards on the shower or a bathtub, as well as throw rugs in the house that might be causing a trip leading to falls. For our third polling question, we want to know what you think. According to CMS MIPS guidelines, what is required if an older adult reports a history of falls? A. Immediate referral to physical therapy. B. Multifactorial risk assessment including extrinsic factors. C. Prescription of vitamin D supplementation. Or D. Annual cognitive screening only. The correct answer is B. Multifactorial risk assessment, including extrinsic factors. The other geriatric syndrome is incontinence. It's just a screening. It's kind of an embarrassing topic, particularly for women, so it's not always their first thought when they come into the clinic. They may admit they have bladder problems, because generally there's kind of a bias. It's kind of ageism that urinary incontinence is supposed to be normal with increasing age. It's not. These are some of the questions that you want to consider and ask. Do you ever leak urine when you don't want to, when you are coughing during exercise, or on the way to the bathroom, or when you get up at night? Enuresis is not such a big deal in older adults, but also that could be another point of inquiry. The big one in geriatric syndromes is cognitive status. We want to use our screening tools. The quickest one is the mini-cog test for memory, and then also the PHQ-2 for depression. Most folks are familiar with those 2 tests. With geriatric syndromes, we want to screen for neurosensory loss. Vision and hearing screening are important. It's a requirement for the initial annual wellness exam by Medicare. Medicare does cover glaucoma screening. The other point is that audiometry is the gold standard for neurosensory hearing loss. The whisper test is pretty predictive. That's where you stand 2 feet behind the individual, whisper a letter and a number, and they will repeat that. We also want to consider screening for geriatric mistreatment. There are 2 components. One is elder abuse. Those might be identified by unexpected contusions, burns, bite marks, general rectal trauma, as well as pressure ulcers from sitting around, which includes heel pressure ulcers that may not have broken open, but have softness on the bottom of the heel. If they have a low BMI, these should all be considerations for mistreatment or self-neglect. Diogenes syndrome, which is one of the more interesting syndromes that we see in geriatrics. These are people that typically are hoarders and are very homebound. They collect anything from cats to books. For social determinants of health, there's a very good scale for loneliness, called the UCLA Loneliness Scale. Ask individuals if they have any concerns about their money, particularly if somebody has taken their money unexpectedly. If they have cognitive dissonance or memory loss, they may also have paranoia or delusions about people taking their money, as well as authentically. Sometimes, somebody did actually take their money. Most oftentimes, it's an adult child who wipes out the bank account, and that all needs to be interrogated and followed up, either through your own efforts or through a referral to social work, and then through the Department on Aging for Elder Abuse. Check the home environment. Look for anti-slip for the tubs and showers, and look for trip hazards. This Edgar Degas painting shows a woman bathing in a shallow tub, obviously with no anti-slip devices. There's no hand bar or rails. That probably would qualify as a bad situation in the geriatric assessment. You also want to inquire about assistive devices, such as cane length. Does it go up to their wrist and no higher? If they do have assisted devices, do they actually use them? A lot of patients will come in, and they'll say they have a walker, but it's in the closet. You also want to have carbon monoxide and smoke detectors. Make sure the batteries are updated. It's also important to point out to the older adult that their hot water heater not be above 120 degrees Fahrenheit to avoid burns. Consider a driving assessment. Typically, these are done by occupational therapy, but also you can refer to AARP for their safe driver course. The driving assessment needs to go hand in hand with the cognitive assessment. If somebody screens positive for the mini-cog test, you need to drill down what their driving inclinations are, whether they've given up the keys or still continue to drive. Consult the CDC guide for adult immunization annually because it changes. Influenza is important to have and prescribed annually. The high-dose influenza shot is generally preferred in the 65 and older population. The new recommendations for the COVID-19 vaccine, it's one set, whether it's the RNA with 2 doses or the alternative versions with 1 dose. The follow-up needs to be determined as of when this presentation was put together. With the pneumococcal vaccine, there's a couple of options. You want to give 1 dose of the 23-valent vaccine, unless it was given prior to the age of 65. Sometimes people with lung disease are given pneumococcal vaccine in their 55 to 60-year range. A discussion needs to be had with the individual about the 13-valent and the 23-valent given consecutively. If somebody wants that higher booster effect, then they need to be given in a sequence of the 13-valent first, and then 1 year later with the 23-valent. You can actually reverse them, but it depends. There's some controversy about the overall efficacy of having both immunizations, but minimally you'd want to do the pneumococcal 23-valent. With the other immunizations, hepatitis, hemophilus, and so forth, those are generally reserved for individuals that are asplenic and immunoinsufficient, including people on medications that are part of the complement inhibitors. Also, there are some updates since 2023. RSV has emerged as a key preventable threat in geriatrics, similar to flu or pneumococcal. Recommend discussing with all 60 and older patients. Prioritizing high-risk groups, it's a one-time shot with good safety, but watch for rare Guillain-Barré, about 11 excess cases per million. Co-administer with flu or COVID if needed. This fills a gap in respiratory protection for vulnerable elders. Pneumococcal guidelines evolved in 2024 to 2025 with PCV21 addition, simplifying to a single higher-valent vaccine for broader coverage. Discuss this with patients who've had older versions. There's minimal controversy on efficacy, but it ensures better protection against emerging strains in immunocompromised elders. COVID recommendations now include annual updates like for flu, for 65 and older, a second dose boosts protection amid variants. Evidence shows 56% effectiveness against hospitalization. It's not one and done anymore, but adapts to ongoing risks. With chemoprophylaxis, there's a drift away now from aspirin as primary prevention in the older adults. If they do have a 10% or greater cardiovascular disease risk, then mini-dose aspirin is recommended in the what I call the young old. As of the 2022 USPSTF updates, aspirin isn't for primary CVD prevention in 60 or older patients, as harms like GI bleeds dominate. For those already on it, use shared decision-making. Evidence from large trials shows quality-adjusted life years are lost, but for high-risk individuals under 60, it might still apply. Those individuals at least in a geriatric practice, 65 years to up to 70 in terms of vitamin D. The American Geriatric Society recommends a 1,000 international unit daily and 1,200 milligrams daily of calcium. There is some controversy about taking calcium, particularly in women, is causing some additional problems that are vascular in nature. It's important to follow up with the randomized control trials that address that issue. Most diets pretty much have about 1,000 milligrams of calcium in them daily, so supplementation would be to get that 12 to 1,500 mark or eating small containers of yogurt daily. The 2024 USPSTF draft confirms no benefit for vitamin D or calcium in preventing falls or fractures, but evidence leans against supplementing unless deficient. Also focus on exercise for falls instead. There's no evidence that multiple vitamins have any impact on functional longevity or lifespan. There is some evidence that vitamin E may lower lifespan, so be careful with vitamin E supplementation. This is a very popular supplement in some of the anti-macular degeneration preparations. Look to see if people are taking multiple vitamins, particularly things like Acuvite or these other eye-type multiple vitamins. If they're also on anticoagulants, there might be some interaction with vitamin E as well as with fish oil. In addition to some of the anticoagulants like A and apixaban, for hormonal replacement, it's not recommended. Recent 2023 to 2025 randomized controlled trials with testosterone in men, T-trials, Traverse, show more positives than previously demonstrated, such as muscle gain, fat loss, and no major CVD rise. But there are risks like fractures and atrial fibrillation. It's recommended for symptomatic hypogonadism only, with lifestyle changes first. Individualized treatment, as evidence supports it if a deficiency is confirmed in estrogen and progesterone replacement in women. It's associated with increased cardiovascular disease and possibly breast cancer. There is some evidence that estrogen replacement may be beneficial in brain function, and there's continued research in that area. 2025 guidelines, NAMS aligned, shift from blanket avoidance of prescribing. Hormone replacement therapy relieves symptoms effectively, 75% MEMS reduction, and protects bones if timed early. Transdermal is safer. Use the lowest dose and focus on the short term with monitoring. It's really important to try to get a handle on a lifespan of the individual. One of the better reference tools is what's called ePrognosis. This is from the University of California at San Francisco. UCSS ePrognosis was updated after 2023 with integrated tools for multi-outcome prediction. For example, a 70-year-old male now shows disability risk too. I put in a healthy 70-year-old male and accumulated some points. With male gender and age, you get more points. You can see what the relative 5-year mortality, 10-year mortality, and then 14-year mortality might be. Sharing that with individuals might be important. Use this for making shared decisions on screening. It's evidence-based, but empathetic. Talking about a 1 out of 4 chance of passing away within a 10-year period might stimulate some thoughts about getting advanced directives in order, and so forth. These types of screenings are valuable for engaging in talk about what matters to the older adult, and to start looking at their advanced directives. The sooner the better. Everybody should have advanced directives, but as people start approaching 75 years of age, there should be 100% of those individuals with advanced directives.